I, Dr. Prashant, welcome you to this webinar on Carbetocin in action. At Heathrow, we market products in different therapy areas like in gynecology, obstetrics, dermatology, etc. We have a strong R&D support and we have developed many unique formulations keeping patient benefit in mind. Recently, we have introduced Carbetocin. Carbetocin, as we all know, is used for prophylactic management of PPH. PPH is a condition which can potentially lead to a disaster. Whilst there are several papers and guidelines which suggest use of Carbetocin, it is very important to get experience of our own doctors on use of Carbetocin. And we have eminent speakers to give insights into their experience with Carbetocin. Today we have Dr. Ritu Dargan with us. Welcome, madam.
Thank you. Thank you, sir.
Dr. Ritu is Senior Consultant at HOD at New Era Mother and Child Hospital, Nagpur, Director Integra Specialty Clinic, Kamla, Nagpur. Madam has done MBBS and MD from MGIMS Sevagram, Postgraduate Diploma in Medical Legal Systems from Symbiosis, Pune, Diploma in Emergency Obstetric Care from Karolinska University, Sweden. Madam was ex-Associate Professor, Mahatma Gandhi Institute of Medical Science, Sevagram. Dr. Ritu has special interest in high-risk pregnancy and is actively involved in community activities which include training of ANMS for detecting high-risk pregnancy, prevention of PPH, etc. That's very great, madam. Prevention of PPH is a very noble cause. Welcome once again, madam.
Thank you, sir.
But I mean, we'll go straight away to your slide case. This is case study.
Right. Yes. So I'll just be talking about 3 cases in 3 different scenarios. And I've been using Carbetocin now almost, I think, it's been 2 years. We've been regularly using it and not had a single problem as such. So I'll just discuss these 3 cases that we had. So the patient was a second gravida, 39 weeks, came in active labor. She was a known case of gestational diabetes with polyhydramnios. Baby size was big. So we were anticipating that she is more prone for developing postpartum hemorrhage. So Carbetocin was given intravenously diluted immediately after delivery of the baby. And luckily for us, there was average bleeding and even her postpartum period was quite uneventful. There was no secondary hemorrhage or anything after that. The next case. Yeah, this is in a high-risk pregnancy. She was a patient who was primary, 34 weeks with severe preeclampsia. There was an intrauterine fetal demise with abruptio placenta. Her blood pressure was more than 180, 120. The cervix was unfavorable, so it was decided to take her up for emergency LSCS. Intraoperatively, we started Carbetocin at the time of the uterine incision. And there was almost on intraop, there was covulare uterus, there was a hemoperitoneum was also there. There was 1 liter of retroplacental clot. But again, we were able to manage her with no atonic PPH because in these patients, you anyway do expect postpartum hemorrhage is very likely, especially with an element of DIC setting in sometimes. And if atonicity because of the covulare uterus and there is extravasation of blood into the myometrium, so the uterus does not contract. But again, this patient was managed without any untoward consequences. Next case study, please. Yeah, this is the use of Carbetocin, which was used later on in atonic PPH. She routinely underwent an elective LSCS in view of breech presentation. After 2 hours, the staff informed that there was excessive bleeding per vaginum. On per abdominal examination, the uterus was flabby and the height was the uterus was also around 26 weeks. Per vaginum, there were clots present. So we immediately started bimanual compression and uterine massage was started. And simultaneously, she had received oxytocin intraoperatively. And 10 units of oxytocin was given in the drip. But we gave Carbetocin and Methergin because at that point, you don't want to waste time thinking of the drug. So we gave both actually. But uterine bleeding again reduced and within 5 minutes and the uterus was well contracted. We were able to evacuate all the clots and patient was monitored strictly and she continued to remain stable with no further episodes of bleeding. So these are the 3 case studies that I had to share and my experience with Carbetocin has been good.
This is wonderful, madam, especially in patients with LSCS when she had so many clots and immediately it went into, immediately the uterine contracted.
Yes.
Now, coming to some of the questions, overall, how is your experience with Carbetocin? Overall, like you said, you have been using it for 2 years. How is your experience?
Everything, I don't think there's been any problem. Only thing what my anesthetist has usually noticed is there is a transient tachycardia that takes place. But that settles within, I think, 10 minutes of that. But
But
we've
is it
noticed that because we do attach the chest leads to every patient. So that's why we've been able to monitor. But there are no arrhythmias or anything. It's just transient tachycardia which settles.
is it more common with IV or even IM gives the tachycardia?
We have been using IV only because we have
Okay.
been diluted shift because the anesthetist usually gives it. So we've been using it IV. Intramuscular is used during vaginal delivery. So at that time, we don't get to know whether tachycardia is there or not
That's
because
right.
the
That's right.
monitors are not
Yeah.
attached. That
Yeah.
time, yeah.
And by and large, it is a routine type of delivery. The
Yes.
second case which you showed, that's a very interesting high risk pregnancy. I mean, patient with IUFD with hypertrophy placenta. It is fortunate for the patient she came out smoothly. Otherwise,
Yes.
this could have been a critical case.
Yes. We had a similar patient where we almost, she did go, we had to give her almost, I think, 8 or 9 blood transfusions and fresh frozen plasma.
1 liter
So
of
they
retroperitoneal
sometimes
clots
do
is
land
big.
up, they can be very tricky.
Yeah. I mean, I was amazed. This is God's grace. Patient was. In fact, in our practice, we always expect the unexpected.
Yes.
So this is about your experience in Carbetocin, using Carbetocin. What is a patient profile you would feel, where doctors can anticipate PPH apart from high-risk patients? Any specific profile that doctors have?
One is if there is previous history of postpartum hemorrhage, you always have to be alert, especially in second gravidas. Grand multiparas, those who have had previous 2 or more childbirth. Elderly patients, obese patients also are more prone for atonic PPH. And other than that, your high risk cases, you have multiple pregnancy, polyhydramnios, all these patients, hypertension in pregnancy, gestational diabetes, all of them are more prone for postpartum hemorrhage.
Even patients with fibroid, I suppose.
Yes, fibroid uterus also.
And post-date patients, madam.
In fact, fibroid, when you talk about fibroid uterus, we've done, I think, more than 5 or 6 cases in the past year where we've had pregnancies with fibroid uterus.
Okay.
We've given Carbetocin and we've also managed to remove the fibroids during the cesarean section without any excessive
additionally, yeah, lovely. That is great. Yeah. And patients who are post-date, pregnant patients who are post-date.
Yes, post-date also done.
Yeah, because the fetal size would increase and again it will lead to
again, macrosomia, that's where macrosomia.
So in patient profile where we expect anticipate PPH, it's better to straight away go for a drug which would, give you a good contraction and a fast onset of action. Where would you prefer and when would you prefer Carbetocin or oxytocin? Oxytocin has been our textbook brand. We have read that in all our textbooks, whichever textbook we follow. But the specific case...
I'm using it for all cases. We are routinely using it.
I mean, if you have the best thing with you,
our center has been, we've been routinely using it.
And you know what? I mean, what is at stake? Finally, life is at stake, something happens. So it's better to use the best one and possibly get the best contraction. Yes. Can you
oxytocin we use mainly for induction of labor. It's used more for induction rather than...
Yes. Correct. This oxytocin is used for induction. Can you use Carbetocin in case of retained placenta?
You can use it, but after you've removed the placenta, because the placenta is retained. So once you're planning to go in for a manual removal of placenta, I don't think that, because it doesn't cause, it doesn't act like methergin.
Correct.
The mechanism of action is not like methergin, where it causes closure of the os. So it's, in fact,
if os is closed, then
inadvertent administration of methergin actually leads to a retained placenta.
Yeah, correct. Because the os will be closed and yes.
Yes, so that problem we don't see with Carbetocin.
Okay, the os closure is not a problem with Carbetocin.
Yeah.
But in the retained placenta, of course, with the removal of placenta, sometimes I suppose again the PPH could start.
Again, yes, there is risk of atonic.
And how common is this retained placenta? Or you expect in any patients?
Quite less. You don't see it. Okay. I don't see it frequently.
Now, this is a question which has come across India. Can we use Carbetocin in RH negative mothers? Dr. Yes. And this is very important because if RH negative mothers go for PPH,
in fact, you want to reduce the blood loss in RH negative
as much as you can. Correct. And in cities, big cities, places, it will still be possible, but in the interiors, it will be very difficult to get RH negative blood. Correct. Can a doctor use carbetocin for prevention of PPH? If, I mean, you have already answered this. Oxytocin is used for labor induction. We have all been using oxytocin now for labor induction.
Yes, I don't think there is an issue because we have been using it.
And the receptor fatigue, nothing happens if oxytocin is used.
The reverse I've seen. If you've used carbetocin and then you want to use oxytocin, it doesn't work.
It doesn't work. It doesn't work. Yeah, it would not work. I mean, that's a powerful drug. Ultimately.
It doesn't work.
Would you prefer IM? Now you have been using IV, but if I have to ask you, IM route only for plain vaginal deliveries, you said.
I am, yes, in vaginal delivery, but usually routine cesarean sections, IV is being given.
Yes,
My anesthetist usually dilutes it and gives it IV.
And again, a slow injection,
Slow injection,
not a
yeah.
bolus, yes. Because bolus would again lead to
usually she starts it when I'm at the level of the uterus. I'm opening the uterovaginal vesicle fold. So by the time the baby is out, the placenta just comes out. So by the time you clamp the cord, the placenta expulsion also starts. So your blood loss is actually minimized a lot.
If the patient is not responding adequately with carbetocin, what additional uterotonics you would use?
Methergin is one, methyl ergometrin, first drug of choice. Then carboprost, prostaglandin F2 alphas, and misoprostol.
Of course, methergin, the blood pressure problem will always be there.
Unless a patient is hypertensive, then that's an issue. But otherwise, misoprostol is a good option. That misoprostol also can be used.
And carboprost again, that asthma, allergy, etc.
There's a certain way where you cannot use. So the safest is
misoprostol. But how frequently you have seen this? Someone not responding to carbetocin?
They have been 1 or 2 patients, not many, but yes, they have.
Always that will be there. I mean, no drug can ever be 100%. Yes. What are the advantages of carbetocin or oxytocin? One thing I really feel is that cold chain not requiring.
Yes, cold chain, and plus I think the sustained action.
Correct.
It gives a longer duration of action.
And not requiring the IV line itself is an advantage.
Yes.
Not requiring an IV line. Because if IV line is required, then again in the interior that could be a problem. Yes. So over misoprostol, any advantage?
Misoprostol does tend to cause a lot of rigors at times. Most of the times we do see patients having rigors with misoprostol. But otherwise, misoprostol has also been a lifesaver.
And misoprostol, the blood pressure can fluctuate again. I mean, do you get immediate rise in blood pressure with misoprostol?
No. With methergin you do, but with misoprostol, no.
You don't get.
No.
With carboprost, I suppose that prostaglandin reaction could be immediate, I suppose.
Yes. But even then, PIH, we do use carboprost. Methyl ergometrin, yes, that can cause an elevation of blood pressure. But the other 3 drugs, no.
Other 3 drugs, there is no risk of blood pressure. And with methyl ergometrin, I mean, the combination route is IM, I suppose. No, you don't get IV methyl ergometrin.
We do give sometimes, but then patient usually vomits immediately if you push it fast.
Okay.
So they usually dilute it and give it. Yeah. So
and even if intramuscular, there is an immediate shoot up of blood pressure.
IV causes more. With intramuscular also, it does cause within 5 minutes, you'll see the BP rising.
BP rising. Then again, there is headache, BP rises. And misoprostol and carboprostol, they don't require cold chain.
No. Carboprost does require a cold chain.
Cold chain.
Misoprostol does not. Carboprost is...
Methyl ergometrin requires a cold chain? No.
No.
Should a carbetocin be used as a reserve drug or should be used as a first line?
I think a lot of times, I think the only hesitation people have in using carbetocin as a first line is the cost, maybe.
Cost, yes.
That is the only hitch I think that is coming. Other than that, because now we are using it as a first line, I am using it as a first line.
First line, yes. Right. And I mean, finally, when life is at stake, you should use the best one.
Yes.
Yes. Cost is an issue, but maybe the other advantage is for carbetocin essentially is not requiring a cold chain.
Right.
And adverse effect profile, contraindication of carbetocin or oxytocin or other uterotonics.
I have not seen any severe side effects, adverse effects with carbetocin, other than the transient tachycardia I told you.
Any risk of embolism you have seen?
But it has not had any effect on the hemodynamics of the patient.
Okay.
But oxytocin, if you give it fast IV, it does
Oh.
tend to cause hypotension at times.
Hypotension.
Yeah.
And retention of, I mean, that ADH effect would also be there with oxytocin. I suppose.
Antidiuretic hormone
Yes,
effect, yes.
effect.
So there
So
is
there will be
reduced
water.
urine output, and a lot of
Yes.
times we have had to give Lasix to the patient
Correct.
if
Maybe
she's
water,
received too much of oxytocin. Yes.
Water accumulation and electrolyte imbalance, again, that would happen. Now, all in all, take home message for the audience.
I think it's
Safety,
a safe, effective, and well-tolerated drug.
and you have been using it for 2 years.
Yes, 2 years now. Our center is now 2 years old, so we've been using it regularly. So
Without any major side effect, apart from
without
tachycardia.
any, never had any major side effects.
No, thank you very much, madam, for your insights. Especially we got good insights, because you have started using straight away in cesarean section IV, otherwise IM. So very good insights that we have. We also realize how fast it acts, and the safety of the drug over so many years. Tachycardia is a side effect which is sometimes seen.
Yeah.
Thanks once again, madam.
Thank you so much. Thank you.
And thank all the participating doctors who took time from the scheduled and attended this webinar. Thank you, marketing team Hetero, for conceptualizing this program. Thank you, field personnel Hetero, for coordinating. And last but not the least, thank you, IT team, for your IT support. Thanks once again, all of you. Thank you. I'm signing off, madam. Wish you a very pleasant afternoon. Thank you.
Thank you.
Hello?
Sir, you are in mute.
Thanks म्हटलं मी.
हो
परत 5 वाजता तू येणार ना?
5 वाजता पण आहे का?
अरे नाही, तुझा मेन डिव्हिजनचा आहे तुझा.
ओके,
मेन
नो
डिव्हिजन.
इश्यू. चालेल, थँक्यू सर. चलो सर, बाय.
थँक्यू.
Thank you, Sachin.
थँक्यू.
बाय.
थँक्यू.
Bye.
भैया रास्ता भी खाली लगे